So, welcome. And tonight is a special night because it's the night before our summer break, but also because we have not only a fantastic cast of panelists who are joining, which we'll introduce in just half a second here, but we also have a really, really interesting case. And this case is interesting because it really has two parts. And as most of the cases with these bounce back critical care chapters, we focus on the return visit, not as much on the initial visit. This one, we're going to focus a little bit more than we usually do on that initial visit, not on just when the patient returns, although we'll see that when the patient returns, there's a lot of really good discussion points. So I wanted to, first of all, thank Crystal Tallman for joining. She is not only emergency medicine and critical care, but also chapter author of this chapter 22 out of the total 30 chapters. So I think with us getting started again on the first Monday in October, we are going to be able to finish the book in the next calendar year, which will be fantastic. And I am also really honored to welcome Amal Mattu, who everybody I think on this call probably knows, as well as most people watching. And Amal's not only emergency medicine, University of Maryland, but a really true, not only emergency medicine cardiology expert, but and Amal, I know I'm going to make you probably blush a little bit here, but really one of the very best medical educators around. So we've been working together for years and years, and I just have to say I'm just always truly honored and really enjoy the work that we've done together, not only just on programs like this, but also writing and also programs we've done live together, which has been really nice. And speaking of medical education, we have Mac Brown, MacKenzie. So Mac is the cool way to say it though. So I'm going to keep saying it that way. And he is a emergency medicine physician, but also a med ed fellow working with Jess Mason, who is also a chapter author for this chapter, but wasn't able to join us. Evan Price, senior internal medicine resident at my program at Adena Medical Center, and he is finishing and starting a critical care fellowship in really just a few months. And also Lauren Schuermann, who is a fantastic medical student who is going into emergency medicine. So I asked her to join us. She has some really nice stuff to lend to us. So thank you everyone so much for joining. And I'm going to share our PowerPoint here. And just first start off by saying that there are no conflicts of interest here. No one is making money from strokes or making money from, dysrhythmias or making money from anything with this. So no financial disclosures. For folks who want CME credit, please shine your phone there. I'll leave this up for just half a second, and you get 1 hour of free CME credit, which is really nice. And thank you, Adena, for providing that for all of us. This will come up again at the end of the program. So if you miss it now, or if you're joining late, no problem. We'll flash it up towards the end. So here's the folks that are on the program, and I've introduced everyone so we can rapidly move past this. So folks that are joining, you have chosen to give us an hour of your time, and we hope to be true to it. So we're going to hopefully give some information during this program that most importantly is going to help with patient safety, but also hopefully help with our own medical care and maybe even some risk management type of things, some confidence and competence, which I think are the two things that help us sustain a career in emergency medicine. So this is a story of a 53-year-old man who has a past history of atrial fibrillation. And I'm going to just show you the actual documentation from his initial visit. So I've talked about the fact there's two main themes with this. And this is a patient, like many of our patients, who has a lot of stuff going on. He has a history of SVT and AFib, and I'll get your thought on that in just a second. But sometimes when people say they have both of those, I sort of think to myself, it's like, maybe they don't really know that for sure, but maybe that is actually true. He said he had the onset of palpitations at rest about an hour prior to arrival. So he gives a pretty defined time, but we'll see if that's actually the case. He said he'd had symptoms previous. He had been prescribed metoprolol, which he's not currently taking. No other symptoms, sort of a short type of review systems, chest pain or shortness of breath. There's some other things that could be going on. He does have lightheadedness. And then like many of our patients, he just throws this in at the end. He used methamphetamine a couple of days ago. Now, this is curious, and we had a little bit of conversation prior to this call here about his heart rate, because the way that it was documented, and at the time, like many of our patients that we see, we weren't at the scene. We don't have the rhythm strips, right? So they say, the paramedics say, that the patient's heart rate was 250 beats per minute and he was hypotensive. And so they cardioverted him in the field. So I'll just very quickly go through the end of this. Here are some more review systems here, but as far as the actual history of present illness, maybe we have what we need to know. Maybe there's some other information we could have found out about. When he gets to the ED, his heart rate is fine. It's 67. His blood pressure is good. The EKGs, two are done, first showing that he's an AFib with a rate of 156, and that's I think when the vital signs were recorded, shows that he's in normal sinus rhythm. And the cardiology team was consulted. They decided to recommend rivaroxaban, and we're going to have the patient follow up as an outpatient. So that's sort of the end of the documentation, 3 different sheets, and I can sort of go back to that at times if we want. But Crystal, I'm going to sort of start with you, because this was a patient that you actually know, or maybe even a patient you cared for. Tell me a little bit more about that. I'm always encouraging the residents to get in the room while the paramedics are still there, because they seem to like drop those patients off and skedaddle, right? But sometimes you can get some really good information. What is the additional information that's not on this chart that maybe you have knowledge of at this time?
Yeah, well, I will say we were a little befuddled as to what the original rhythm the patient was in was, because the medics did not have the ability to print a rhythm strip because their Zoll was out of paper, which is real world,
Of
right?
course.
So we didn't really know. We were kind of skeptical, like, was this SVT? Was this a different rhythm? And we really had no idea. But they told us that it was a fast, kind of narrow, complex, regular rhythm, and that he was hypotensive with a systolic blood pressure in the 50s and pale and like diaphoretic.
Okay, so we have on here that they emergently cardioverted the patient. When they got to the ED, it's interesting, the EKG, the first one is AFib. Did this just spontaneously convert to sinus rhythm?
Yeah, that's right. We didn't shock him further, give him any medications. He was conversant with us, able to give a full history, like asymptomatic, and in no distress, normal vitals.
Okay, so maybe it was just your healing touch. He gets there, you put the stethoscope, if you still use those, on his chest, and he just immediately went down into sinus rhythm. That's fantastic. So, Amal, this rate is curious, and I sort of alluded to the fact that we had this conversation beforehand. What are your thoughts? Was this a true rate, or maybe they didn't count correctly? But if it was a true rate, what are rhythms that actually cause that fast of a heart rate?
Yeah, I think the rate really is unusual. And for a rate to be 250, to me, that largely rules out normal atrial fibrillation, because AFib just doesn't go that fast unless there's an accessory pathway. And if you don't see evidence of an accessory pathway post-conversion, then it really makes me skeptical. SVT sometimes can go really fast, 220s, 230s or so. And then the other thing that you'd worry about is maybe he was in polymorphic VTAC, because that can certainly account for him becoming hypotensive. Rapid AFib, interestingly, very rarely causes hypotension. It's actually the underlying process that usually causes hypotension, unlike what ACLS makes us believe it's all very cut and dry. But normally AFib doesn't produce hypotension unless it's like AFib with an accessory pathway or the polymorphic VTAC. So I have to think, maybe this actually was polymorphic VTAC, because if there's no accessory pathway, AFib just doesn't go this fast.
So, Amal, a little follow-up question. This might be a bit of a branch point, but AFib with RVR sort of probably is defined as over 100, but there's a huge difference between AFib with a rate of 101 and AFib with a rate of 160, 170. I had a patient just a week and a half ago who actually got cardiasm from the paramedics, which I was a little bit surprised about, honestly, for AFib with RVR with the rate in the 140s. As it turns out, then when I saw the patient, it turned out that he had Fournier's gangrene and went for emergent surgery. So he more had a tachycardia with underlying AFib as opposed to being a primary arrhythmogenic type of process. Is there a cutoff number that you use when you call something AFib with RVR, or is it just anything over 100?
Well, I guess the diltiazem didn't treat the Fournier's gangrene too well. So
Look, it wasn't Zithromax,
yeah,
right? So,
right. Well, that would have been the solution to everything, right? Or listen,
everything,
or
right?
Pen VK. So I think a lot of it is semantics. I mean, you could call AFib with a heart rate of 110 AFib with RVR. There's no formal definition, to my knowledge, of what RVR means. It just means that you've got AFib and the heart rate is really fast. I think that first R probably stands for really. I'm not sure how to work out the VR. So there's no specific heart rate that qualifies for AVR. I think just if they're persistently tachycardic, that tends to be used. But I honestly, as you're suggesting, a heart rate of 140 generally is not that concerning. You want to do something about it, but you don't necessarily need to treat the rate. You need to look for an underlying condition. And like I said a minute ago, it really is unlikely that rapid AFib causes hypotension. Again, putting accessory pathway aside, AFib with the heart rate of 140, 150, 160 usually doesn't cause hypotension. It's very rare. I mean, maybe if you get up to 180 or 190, possibly. But I think it's important for people to understand that when you see a person who's hypotensive with rapid AFib, you really ought to be thinking about some other underlying condition that's causing the hypotension and not just focus on, hey, I'm just going to cardiovert the patient, get them back to a lower heart rate, and the hypotension is going to be gone. It doesn't, unfortunately, work that way.
Gotcha. Okay, final question for you while we have you here, right? The AFib with WPW. Give us some subtleties, some sort of next level teaching points on that.
So AFib with an accessory pathway, WPW, is going to be irregularly regular. And the really important things you're going to see is that the AFib WPW can get really, really fast. You can get patches of that rhythm where the heart rate can be 250, 300 beats per minute. Normal AFib just doesn't go that fast. And then the other really, really important distinguishing feature is that generally with routine run-of-the-mill AFib, you look at the QRS complexes and they pretty much look alike all the way across. Whereas AFib with WPW is going to have a lot of variation. So you're going to see some complexes that are narrow, some that are wide, really wide, and then a lot of fusions. So you're going to see heart rate, you're going to see QRS widths that are all over the map. And again, very rapid in certain areas. So I always have this mantra, irregular with morphologies that are changing, and in some places 250 to 300 beats per minute. That's what characterizes AFib WPW, whereas normal AFib with a bundle, say, or without a bundle, the QRS complexes are going to look pretty similar all the way across. And it's a very, very big difference in terms of how you treat the patients.
It would be pretty safe to say sinus tach would not go up that fast.
No, I mean, there's a general rule that the maximum sinus rate is 220 minus your age. And so if you have, for example, a 20-year-old, you can get sinus tach up to around 200. But if you have an 80-year-old, then they're not going to have sinus tach faster than about 140, if my math is right. So 220 minus your age is the general rule that we follow for the maximum sinus tachycardia rate you're going to get.
Okay, gotcha. All right, so Mac, next question for you is, there's this thought, obviously, with AFib, with RVR, right, that you can do rate control or rhythm control. This patient had a pretty defined time of his symptoms. On the other hand, he said he used meth 2 days ago, but maybe it was 2 hours ago, right? How reliable is that? We know he also has a past history of AFib, so, obviously patients that can have that. Give us some thoughts on anticoagulation, cardioverting stable patients, if we'd want to anticoagulate them, how long we'd have to do that before it'd be safe to do that as far as any risk of a stroke.
So, per the AHA in general, you're going to want at least 3 weeks of consistent anticoagulation. So you're going for like a DOAC every day or an INR if they're on warfarin of at least 2 to 3. And they have to be consistent with this. So if they're missing doses, kind of resets the timer on that. All of a sudden, kind of no longer in that 3-week window where you're safe to do so.
Okay. Now, as far as this specific patient, and I think I know the answer to your question, right? This guy is tachycardic, hypotensive, diaphoretic. You would agree, no matter what his past history is, no matter if he's anticoagulated or not, this guy should be cardioverted.
Yeah, my favorite Metallica album is Ride the Lightning, and so that's what always goes in my head when like cardiovert someone, you know. You grossly unstable, and then your other people that are within 48 hours of symptom onset are the two people that you can safely cardiovert without that kind of big concern in your head. Unstable, that you got to get that done within 48 hours. You also kind of want to get that faster, as fast as you can.
Okay, gotcha.
Yeah.
All right, perfect. All right, so Evan, being a internist, I know this is like focusing on a lot of the ED care here. Um, Tell us a little bit about this, and this is a little bit of a branch point also, the Chad Vask 2 score. Are we still using that? You know, obviously everybody in AFib doesn't need to have anticoagulants. Is aspirin helpful? I mean, give us just sort of a thought on patients with AFib, risk of stroke, why we anticoagulate, and how helpful or efficacious that actually is.
Any person with AFib has around I believe it's a 4 to 5 times higher risk of stroke in a year, just predisposes them to it. And then we do still use the CHADS VASC2 score to kind of delineate low risk versus high risk. And that takes into account other comorbidities, hypertension, heart failure, the patient's age, do they have diabetes, have they had a previous stroke, and then it gives them a point system. So for example, I always remember 2, 5, and 9. So if they have a CHADS VASC of 2, which majority of the patients that we see in Southern Ohio, they have a high risk. So they're normally getting a DOAC, but 2 is 2.2% risk of a stroke in a year. That's the thing that we always have to remind people. It's over a year.
Okay. Gotcha. So very much is on the side of, you know, especially if there's some other risk factors of anticoagulation. But we see a lot of younger patients in the ED and they've had AFib in the past and they aren't anticoagulated at all. I assume the risk for them is much lower. Maybe the risk of anticoagulation is higher than the risk of stroke in, you know, a 30-year-old or 40-year-old.
It is. It does increase with age, just in general, and then obviously throwing AFib on top of that is just compounding the issue. So if it's a younger patient, no comorbidities, then usually you don't have to anticoagulate. So men, if it's below 2, and then women below 3 is usually the cutoffs that we tend to go by.
Okay, gotcha. All right. And for anyone that thinks that I have forgotten Lauren, I have not, because we have some parts for her in the, you know, as we're going forward here. So do not think that I have forgotten her. But I wanted to do this. I'm going to back up just real briefly. And I thought each of us, we could maybe even go in the order they went in. So Crystal, then Amal, then Mac, then Evan. And Lauren, if you want to throw a thought in also, one sort of teaching take-home point from this first visit, or maybe something that could have been done better, or something was done well, but one thing that we can take away or take to the bedside on our next shift. Crystal, do you have one thing to share with us?
Well, as a critical care provider, I just kind of want to reiterate the amazing teaching points that Amal said, that, you know, in critically ill individuals, AFib is generally a symptom of whatever is going on underlying their critical illness, and we should focus on treating that. And becoming too focused on the rhythm is to the patient's detriment usually.
Awesome. Amal, do you have a thought on this first part here?
Crystal stole mine. So I guess what I would say is that since the discussion of AFib WPW came up, that again, the key distinction there, look at the QRS complexes, and if there's significant change, then think about AFib WPW. And the reason why that's so important is because with normal AFib, you can use just about anything you want. You can use AV nodal blockers, you can shock them, procainamide, amiodarone. With AFib WPW, the only treatments are going to be either shock or procainamide amongst those I listed. Amiodarone, deadly. Calcium channel blockers, deadly. Beta blockers, deadly. DIDGE, adenosine, any AV nodal blockers will kill that patient. It's a clean kill. So you've got to either just shock them or procainamide. So it's a big, big distinction between accessory pathway versus no accessory pathway.
So I'm going to jump in real briefly. I know I'm sort of moderating this, but I'm gonna move myself to be a panelist for just half a second. So I do a lot of these lectures for residencies, and probably my most requested is called documentation disasters. And so just like you are saying, and I'll be clear in just half a second, I oftentimes tell people it's really nice to say something like, there's an area of erythema and warmth, which is, 4 by 6 centimeters on the inner aspect of the right lower leg. That's great. Really good documentation. But what's even better is to say that and then to finish it by saying, and specifically, there's no evidence of necrosis, ecchymosis, bulla, fluctuance, crepitus, right? And so really, even before you get into the medical decision-making part, what you're saying in your physical exam is you think it is cellulitis and you don't think it's a necrotizing soft tissue infection, i.e. neck fash, right? But in that same way, I would just encourage all of us that anytime you look at an EKG and you're documenting, irregular and a rate of whatever, specifically, we should train ourselves to say something like, the stuff that you talked about, Amal, or, that there's no delta wave, etc. I do not think it's WPW because, how many times you see that in your career of 150,000 to 175,000 patients over the course of, approximately 30 years. I mean, even if it's 5 or 10 or 20 or whatever it might happen to be, it's still super worthwhile to not have what you referred to as a clean kill. No one really wants to have that in their career. Okay, Evan, a take-home point from this first part, and then Lauren, I'm going to ask you for that also.
I think probably, I always tell people, and I always tell myself, look for the reason, kind of what you guys are getting at. Look for the reason for the AFib or the irregular heart rate. Don't just say it's irregular. Oh, well, usually there's a reason. So that's what I would do.
Good. Mac, teaching point from this first part.
I always tell my residents reassessments are kind of worth their weight in gold, and automaticity kind of begets more automaticity. If someone's heart is already kind of messed up, that increases risk of it being more messed up later. So coming back into AFib should be thought of, should be kind of considered, and early loading with an ER beta blocker can save this guy a lot of trouble down the road too.
Awesome. All right, Lauren, do you have a point that you took home either from your own observation or from the discussion?
Yeah, sure. I was just thinking with the initial presentation to the ED, I appreciate the coordination that went on with the ED team and then the cardiology fellow. I think it was important because this patient is at an increased risk for stroke as he does have AFib, whether that's going in or out or if that's just periodically happening. Putting that patient on anticoagulants is going to be beneficial.
Awesome. Okay, cool. So let's find out what happens with this patient. So the patient does, not surprisingly, bounce back, and we sort of switch now from the arrhythmia part to some other things. So it's documented now at 5:45. So about a day later, 53-year-old male presents to ED, altered mental status, last seen normal at 4:40. So about an hour and 5 minutes beforehand, was found in the bathroom with his small child, altered, not speaking, appeared confused. Family called EMS, and when they arrived, he was, they say, sliding down a wall and seemed to have right leg weakness, not following commands or speaking. And then they just sort of state that he was discharged the day before. We already know that information. So this is a now concerning thing, obviously, especially with our knowledge, the fact that the guy had maybe AFib with WPW or maybe some other type of arrhythmia. Maybe it was even, VTAC with that very, very high heart rate. And he'd been put on rivaroxaban. So why don't we, and then this is his physical exam here, just sort of had a blank stare, staring straight ahead. So Amal, I was just going to start off with you, and I wanted to ask a two-parter here. Some things that we should do upon arrival in a patient who's altered. And then interestingly, in a patient who's anticoagulated, we have a couple big thoughts. I mean, it could be either from too much, or I should say, in sort of a funny way, too thick of blood or too thin of blood, right? I mean, there's a couple different possibilities as to what might be causing his altered consciousness here.
Yeah, absolutely. I think in addition to these vitals, you want to make sure to get a finger stick and probably try to find, if you're thinking about the possibility of lytics, depending on your stroke protocol, you want to find out when he was last known normal, if that's possible. And then he's clearly heading for a CAT scan.
Yeah. And would you, I mean, obviously I sort of said it sort of earlier, but I mean, stroke versus bleed, right? Of course, the patient
Sure.
had been putting on this the day before, and that's always a risk. Uh, Patient who has history of drug use or substance use, and then they're anticoagulated, and obviously those patients probably have some type of increased risk of falling. So something definitely to be cautious of. So, Crystal, the olden days, and I should say olden days for me and Amal. I'll date you with me, right? Because we're almost exactly the same age, I think. But back in those days, it was like, oh my God, they're having a stroke. Let's give them an aspirin. I mean, there's really basically like nothing to do about strokes. But now there is stuff that we can do. Obviously, not only thrombolytics, believe it or not, but also, and then more importantly so, endovascular therapy. So in your shop, when these folks come in with what we would at my shop call a pre-arrival stroke alert, where the paramedics sort of call that or at least tell us that that's their concern, do you send those patients, Crystal, straight to CT? Is there a protocol for that, or they still go in a room to get IVs and EKGs and stuff started first?
Yeah, no, they absolutely go straight to the CT scanner, and yeah, I think the delay to wait for a room would not be acceptable.
Okay. And when you have that patient, do you yourself do a stroke scale in the hallway, or do you wait until they come back?
We do like a super quick down and dirty stroke scale in the hallway. Yep, that's what we do.
Okay, but you don't do the full NIH, like, looking at pictures of children on countertops. No, I see you nodding no. Yeah,
No.
definitely not, right? Because you already know you're setting them over, right? And then this is just so basic, but I thought I'd just, for the sake of completeness, um, if they have a history of kidney problems, they're still getting, well, I should ask this first. Do you, and we do non-con plus CTA head and neck. Do you do that initially also, or do you just do a non-con and then have them come back?
So at our shop, we're actually for folks that have a good baseline, known kind of good baseline function and have an rough NIH greater than or equal to 6. We are actually starting with CT perfusion imaging for everybody right now.
Okay, awesome. So you're getting that stuff first, and I guess the question I sort of half asked, but if you have a patient with a history of, stage whatever kidney disease, right, you are still absolutely 100% given the contrast.
Yeah, that's right. We don't wait for any labs but the glucose, and then they go.
Okay. Perfect. Okay, good. And I know we're all on the same page with that. So just wanted to get that out there in case anyone was concerned about that in any way. And even the radiologists, I think, are on board with this now. So that's a really good thing. And we won't have the contrast-induced nephropathy conversation here today. So Mac, within the 3-hour window as far as that initial NIN study or 4.5 hour with ECAS-3, right? And systemic thrombolytic possibility. Well, what if the patient, first of all, is there a blood pressure above which you would not give thrombolytics? And then if that's the case, what medicine is your go-to medicine to bring that blood pressure down and to enable thrombolytics to be given? Say, for example, in this guy who's only 65 minutes from last known normal.
Well, so in this case specifically, looks like everything's ready to rock and roll. For the blood pressure, the biggest thing, kind of culturally, what I grew up on was a lot of cardine. It's what we use. Titrate it. Obviously, you want to taper it down once you get it loaded up. Make sure that you don't keep them on the 15, go down to the 2 or the 3 after you get that blood pressure controlled. The number you're looking for is under 185 over 110. 25 systolic, 110 diastolic. You want to be under those numbers if you're going to give the TPA. If you're not giving TPA, you're aiming for much higher. I know systolic's 220. I'm blanking on the diastolic, but the systolic is much higher, 220 for allowing yourself to continue to perfuse that ischemic tissue if you're not giving the TPA.
You know, it's always amazing to me when patients get sent in for, like, by some primary care, usually, right, with an
Mhm.
elevated blood pressure of like 160, 180. And I'm like, you know, with a stroke patient, we tolerate such higher blood pressures. But of course, that's because they need that pressure to diffuse that edematous area around the stroke, right? So, Mac, one other follow-up question with that is this patient, just for example, other medicines that you would consider, labetalol or other medicines you might consider using in a patient where you want to give, where you want to just, maybe they're like, say, 186, just for example.
Yeah, like a 10 push labetalol, 20 push labetalol, kind of what you're more comfortable with using. Obviously, the labetalol is easy, it's a single dose instead of the drip, so it saves your nurses a lot of time and a lot easier to utilize.
Okay, Crystal, with your critical care experience, do you think are there different medicines you use, or what is your sort of go-to use medicine with a patient over 185 who you're considering thrombolytics for?
No, I would say we would most commonly use labetalol or cardine, as was already mentioned.
Okay, awesome. Okay, so now, and this is going to be, I think, pretty interesting as we sort of get into the reasons why we're sort of going to this next part here. But I wanted to ask Lauren to talk a little bit about stroke mimics. And this is going to be, I'm going to give a little bit of a self-deprecating sort of thing, a story about myself in just a minute here, with a lack of understanding of something that really had to be pointed out to me by a neurologist, probably quite a few years ago. But I think it's going to be pretty interesting because this was part of a very big national dialogue about some of the risks of thrombolytics. But Lauren, you have a list of stroke mimics you want to share with us.
Yeah. So I do. Um, let's see. So some stroke mimics that we'll want to consider. Um, include the ones on the screen right now. So we'll talk about like hypoglycemia, intracranial mass lesions, intracranial hemorrhage, migraines, seizure plus or minus the Todd's paralysis, which is kind of like immediate paralysis after an epileptic seizure. And then this typically resolves itself though. Some other things are we consider like sepsis. Bell's palsy can also present with that facial droop. You are going to have some forehead symptoms with the Bell's palsy, which will lead us away from that kind of stroke symptomatology. So, yeah.
Okay, so a little bit of follow-up on that. So would we be pretty well, and I'm sort of asking this in a way I sort of know the answer to, right? But a patient who does have typical Bell's palsy, and obviously no numbness or weakness, arms or legs, maybe even just for the sake of simplicity, no risk factors, but who maybe is sent in by an urgent care because they're concerned for stroke, because there's this facial droop. Would you feel comfortable, and I know you are a medical student, but hey, look, say, like I always tell you when we work together, you're the only medical provider in Alaska during a snowstorm and the internet is out, right? Um, Typical Bell's palsy, you feel comfortable, even if that patient got sent in, making that diagnosis and avoiding the $1 million workup?
Um, to be frank, I don't think I would feel completely comfortable with that. I think I'd still want to do a head CT just to ensure that there's no stroke going on, rule out the big things just in case. But that kind of forehead facial droop is kind of more diagnostic of the Bell's palsy. But for me, I think I would still get a CT of the head.
Okay. So, and I just wanted to just get other folks' thought on this. And, I think probably some of this is also because of the fact that you work with a lot of different people, and sometimes, as a medical student, you're sort of not only thinking the best medical care, but also thinking maybe what other people would want you to do, right? So I know that that's why one of the very, very difficult things of being a medical student. But one thing I wanted to bring up, especially with the new onset of symptoms, is that if you don't see a stroke on the brain scan, right on the CAT scan, well, you wouldn't necessarily see that stroke right off the bat, right? And in some ways, if you do see a stroke right off the bat, that probably means that this is something that occurred certainly more than 4.5 hours ago. I'll just say for myself, with a patient who does have, really completely typical symptoms of Bell's palsy, and I probably sort of led you astray a little bit by giving you the scenario that the patient got sent in for a stroke workup. But still, we need to still practice our own best care, and that does bump up the risk a little bit, like when we're right at the bedside there. Amal, bring this sort of point home here. I'm sure there are plenty of patients that you see that get referred in, and that at this point, if you get it wrong, that's going to be pretty big implications. On the other hand, we do have that, obviously, that responsibility to do what's right.
Yeah, I think that when patients get sent into the emergency department presumably for a specific workup, we're not necessarily obligated to do that workup. It always kind of rubs some people the wrong way that they're being sent in for an LP or for this or for that. I'd prefer to have them sent in for evaluation than sent in for something. So, you on the other hand, you want to maintain good relationships with the people that are sending these patients over. So I think the reasonable thing to do is do whatever evaluation you think is most appropriate. And if it's not meeting their expectations, you just call them and talk about it and help them understand why maybe they don't need the LP or they don't need the stroke workup. And every now and then they'll tell you something that maybe you didn't get. And then you say, oh, okay, well, if I had known that, yeah, we're going to go ahead and do the stroke workup or LP. So I think just it all boils down to good communication if you're not going to do what they got sent in for.
I love that you say that, because I used to get into trouble a lot with these asymptomatic elevated blood pressure patients. And what I started doing is every single time when someone gets sent in, and it's more than we want to see, but it's still probably just like once a month or maybe twice a month, I don't know, whatever. I'll just call the primary care doctor or clinician and say, hey, look, I have your patient here. And it is incredibly reassuring to the patient to know that I touched base with them, because the patient is really concerned. And look, the patient is not the physician, right? And so they hear about blood pressure and it's bad, and they think they're going to, blow an aneurysm, which, like, literally the number of times that I've seen that happen is maybe zero, but it's just like so low that a patient who is asymptomatic with that elevated blood pressure just, happens to have an acute problem from that, because this is more of a long-term thing that we're looking at, of course. So I think that's a great thought, is, calling that person. And so, probably bring this all home, Lauren. I think that's probably the way to go, is, getting that person's concern, and maybe, again, the patient shared something with them that they didn't share with all of us. So I will give you what happens with the patient. So the actual provider did just what we talked about, and Crystal, just what you sort of said. After a quick exam, patient sent over to CT, and here's what the results come back as. And you can just sort of read that on your screen, and they do have this left temporoparietal infarct. Some labs are done, which aren't really incredibly helpful. And the patient is improving, though. So this is sort of an interesting part here. So we repeat the neuro exam, and then we're now still thinking about something like thrombolytics, because neurology has recommended that. So Crystal, share with us, you said you're doing perfusion, and I'll tell you, at our place, we do the CTA head and neck, but we would either do perfusion, or actually sometimes those patients get sent out for the endovascular part of things. So just give us a little bit more information on the perfusion itself. How does it help us? And in this specific situation, how would it apply to this situation?
Yeah, absolutely. So for this specific patient, he presented very early in his course. He's got a clear LVO on his CT angio, and so I don't think a perfusion study would really make a big difference for this particular patient. The real benefit of the CT perfusion over the regular CT angio is that we can identify core infarct, or brain that's essentially already dead, versus ischemic penumbra, for the amount of brain tissue that's at risk. And what we're really looking for is a favorable mismatch between a small amount of brain tissue that's essentially unsalvageable and brain that can be saved. And so I think the biggest benefit is for folks that maybe present a little bit later in their time course, that sort of 6 to 24-hour window where people can really benefit from thrombectomy.
Okay, awesome. So as far, Mac, as some of the pros and cons for clot retrieval, right? Is there a time span of symptoms that you say, look, it's not going to be helpful, I'm not even going to check for a clot? And with the, obviously, I wouldn't say new literature, but new in the last 5 or maybe 10 years even or so. Boy, this seems like the time that we can really help a patient is with endovascular therapy as opposed to just systemic thrombolytics.
I was muted. A lot of more recent literature is going very aggressively towards like the LVO, and it is making massive differences in a lot of these people that are having M1, M2 infarctions, ICA infarctions. The neurointervention clot retrieval can do a lot more than just TPA can, especially for those very, very large vessel obstructions. And this is kind of the future. This is that, when I was in med school, 7 years ago, my neurology preceptor was one of the earliest guys doing that in Nebraska. And he's having all these great outcomes, all this cool stuff. I'm like, wow, this is pretty cool. Not for me, but this is pretty rad. And now it's kind of, you're starting to see more and more. At my shop, we have neurointerventionists, and I've seen them do incredible work and then turn these people around and say, hey, they can't move half their body. All of a sudden, they're walking out of the ER or walking out of the hospital 3 days later, going to rehab and stuff. It's incredible.
Yeah, it's really insane, and boy, oh boy, it's a groundswell from all that controversy. There's really no controversy with endovascular therapy. So, Amal, a patient is starting to get better. This guy, again, he got here with, if we believe it, and we should probably, but 65 minutes of last known normal. Improvement, is that preclude then use of a systemic thrombolytic? And how much improvement are we really looking for before we would say that a systemic thrombolytic wouldn't be helpful?
I got to be honest. I don't know the answer to that question. It seems to be all over the map. What I've read is that if somebody's improving, then they don't really qualify, but I see it still given quite often amongst a lot of neurologists. And to be honest with you, I still don't have a good handle on it. So I'm looking to find an answer from the rest of this group. What exactly is the answer? So I'm gonna hit my mute button and listen to the wisdom come out here, because there is no wisdom from what I see about this question in my practice.
Gotcha. Crystal, you want to start us off?
Sure. Yeah. No, it's tough. And what I have read and had explained to me by some neurologists is that there can be stuttering, sort of waxing, waning symptoms early in stroke, and things can get better early and then get worse later. And so, unless there's like really just a complete resolution of symptoms, we still tend to give the TPA. And especially if there are symptoms that could potentially be debilitating, like maybe the weakness is getting a little better and the patient still has aphasia or something that's really debilitating for their life, we would tend to still give it.
Gotcha. How about you, Mac?
It's a very tough thing because I know a lot of the reading that I had done, especially for this, and even the people that are getting better with the NHs of 1 and 2s, a third of them still require some form of rehab, God forbid, hospice. And so it's a very hard decision you have to make with that patient and have them kind of put it in their shoes. What would they want when you have that discussion with them? Because it's hard for me to make that decision for them, especially if they're able to talk and communicate with me. I'd rather hash out with them, see what they want to do.
Gotcha. Okay, so Evan, laboratory tests, this will probably be a pretty short answer. Laboratory tests, which ones do you need before you give a patient thrombolytics?
Besides that finger stick glucose, none. You do not need to do anything. You shouldn't be doing anything or waiting.
Okay, and that's the thought, right? To just do this absolutely as rapidly as possible. So I'm going to now move us on to what actually happened here is I think it was a previous I sort of mentioned here that neurology recommended TPA, but the medicine had not yet been given. And the physician, I think, has some reluctance about this. So this is a little bit of a tough situation because physician has reluctance, neurology wants to give. Anytime that the patient sees that there's some conflict here, this is going to be a little bit tough. And I'm just going to give that self-deprecating story that I sort of foreshadowed a few minutes ago. Is when you look at the original NINS data, and it's of patients who get thrombolytics, 6% had a symptomatic intracranial hemorrhage, and 12% had an asymptomatic intracranial hemorrhage, which has been quoted as saying that's still a bad day when you have an asymptomatic intracranial hemorrhage, right? So my thought was, wow, that's such a dangerous medicine. But on the other hand, I remember back to, and I'm not sure if Amal, you were part of any of these studies back in the probably 90s when they were comparing, and this is so crazy, right? But I believe it was TPA versus streptokinase for thrombolysis in acute MI. And, one was like 0.9% rate of bleed, and one was 0.8% rate of bleed. It had like 30,000 people in the study. And anytime there's 30,000 people you have to get in a study with your power analysis, probably there's not such an incredibly huge difference between those two different things. So, the stroke mimics that Lauren really nicely spoke about earlier is a really important thing to think about, because if you have a patient who's having a conversion disorder or hypoglycemia or any of the other things that she talked about, the concern for bleeding is really less than 1%, because the reason that patients with strokes bleed is because they do have that area of infarct, and then maybe the edema around it, and maybe more permeable blood vessels. And actually the rate of bleeding with endovascular therapy is actually pretty high also, but again, still more benefits rather than risks. So let me move to the risk here of giving thrombolytics with a stroke mimic. I know I sort of ruined the surprise a tiny little bit, but I guess I was the one that's going to talk about that. But let's bring this back to ourselves just a little bit here with a legal risk. And I'm going to actually sort of bring in just the chat just for half a second here, because I know, David, you had a quote on here. Let me find how to here we go. Folks in the chat, David Pecora says that Jerry Hoffman is having a seizure right now, hearing that thrombolytics don't really cause specific harm in patients who are stroke mimics. Amal, what is your memory of the whole stroke lytic controversy, the Hoffman effect, as they used to call it?
Yeah, Jerry Hoffman was a very, very outspoken critic of thrombolytics, and I feel like a lot of the younger residents and most of the residents now don't know Jerry Hoffman, but he was really an iconic figure in emergency medicine, incredibly smart, did some of the really best research, and really was a fantastic um, uh, person at analyzing the data. And his best analysis and a few other really smart people really made a very strong push against thrombolytics. And so people would refer to the Hoffman effect because he was so vocal and so well known, and he was a very strong critic against thrombolytics. He has, I think, since retired, and people don't hear from him as much. And the thrombolytic train has really, really moved far down the tracks. So I think that's what this quote really refers to. There's really not a lot of opposition. If I could just put one extra point in here, that whenever you're talking to patients about risk and benefit, it's always really important to talk to them about the likelihood that they're going to improve with no therapy. And people don't do that. So when you look at the original data, if you have 100 patients that have a stroke, 30 actually get better with no treatment. An additional 12 get better with thrombolytics. So when people would talk about the benefit of thrombolytics, you're going from 30 get better to 42 get better. And then on the other hand, 6% will have a dangerous bleed. No one ever talks about the likelihood of improving without any therapy, but that's an important part of the informed consent, which kind of gets glossed over. So I'm not a critic of thrombolytics. I'm kind of like halfway, I guess. But I think if you're going to do it, you need to do it right, and that's what proper informed consent ought to be. And that was one of the things that Jerry Hoffman and also Greg Henry used to talk about quite a bit. And I think it's a fair thing for them to say.
Yeah, I'll add some funny Jerry Hoffman stories. But one other thing about Jerry Hoffman, and I'm sure most folks have heard of the Nexus criteria for C-spine clearance, or maybe you haven't, but he was the lead author on that study too. So his contribution to emergency medicine was immeasurable. He is still one of my true heroes and inspirations in emergency medicine. So this next question here is bringing it back to ourselves just a little bit because we're thinking about legal risk. And I sometimes see neurologists, because we have a robot that we have, a stroke neurologist from Ohio State, will, make the decision really on the thrombolytics. And not as much in the last like year or so, but before that, I think there were just a couple of folks who it felt to me sometimes that shared decision making, SDM, sort of morphed into CYA because they would really put all the nidus on the patient. And to me, it feels like shared decision making has to be decision making between two reasonable alternative pathways, but with our guidance. It has to be with our guidance because if not, we abdicate our responsibility as healers, right? So, Amal, I know I'm sort of going down a little bit of a rabbit hole with all this, but the fact is that the legal risk with giving thrombolytics is probably not near the legal risk as far as patients where we withhold thrombolytics.
Yeah, well, I would say there's more lawsuits at least for
Yeah.
not giving thrombolytics than the number of lawsuits for giving thrombolytics. I don't know if that's the same thing as legal risk, but in terms of the number of lawsuits, it's more frequently for not giving thrombolytics. Um, and so does that make you want to give more thrombolytics? I don't know. I think to me, what the most important thing that you do is you always talk to your patient about thrombolytics because everyone's heard about thrombolytics. Or if they don't get thrombolytics, they're going to go home and their neighbor is going to say, "What? They didn't give you that clot busting drug? I can't believe that." You need to address the fact that there are these things called thrombolytics, and this is why we're not going to give it to you. And that way they know why they didn't get it. And so these lawsuits don't tend to come up as often. I think if you tell them that this drug exists and why you don't think that they're a good candidate for it, or why they are a good candidate and why they should be getting. No one ever talks about thrombolytics when they don't plan on giving it, and they should.
Yeah, and I think it's a good idea that just like we talked about with the AFib, with the WPW, the delta wave, and the different things, right, is to also put in your documentation, patient is not a thrombolytic candidate for these reasons, like intracranial hemorrhage, for example. But I mean, putting that in there could be really helpful. This previous slide is just some data because Steve Goulas, maybe is how you say that person's name, did a meta-analysis of studies that looked at treating stroke mimics. And Lauren, can I bring it back in quick, Lauren? Do you remember just roughly with those studies that I sent you? One was by hand. There was another study also. Of those patients with stroke mimics, what percentage of them received thrombolytics? Do you remember? Just a rough guess.
I'm not entirely positive that I remember how many received thrombolytics. I do remember that it was about 1 to 16% of the patients in the studies were stroke mimics. But thrombolytics, I'm not entirely sure. The other thing I do
Right.
remember is that patients who did end up having stroke mimics and who did get thrombolytics, only around 1% of them ended up having any harmful side effects from the thrombolytics. So generally, they're not very harmful.
Yeah, and I love that you say that, and that's sort of the number that I sort of think of in my brain also. And this study sort of goes a little bit further with saying that it is, you could think just about 1%. Now that's not 1% intracranial hemorrhage, but 1% with some type of bleeding or complication from that thrombolytic. So this is a pretty important study. I'd encourage folks to take a peek at this because this is something that I was sort of not really getting it exactly right because I would say this is a stroke mimic. There's a high risk of bleeding, but it's really the high risk of bleeding just if they've had a stroke, not for a stroke mimic, for example, hypoglycemia or one of those other things that you talked about. So thanks for that insight into that, Lauren. So what happens with this patient is that this patient let me skip that one here. This patient had a MRI of the head, showed left parietal infarct, no evidence of hemorrhage. And in the end, this patient, just like Amal, you talked about, the fact that 30% get better, although, this patient, did get thrombolysis. But anyway, this patient was discharged on day 4 with no residual deficits, but, probably just with some other social issues, this patient did not show up for appointments and wasn't able to reach by telephone. So why don't we get some final thoughts from everyone? While we do that, I'll put the CME credit icon up here. Folks can shine their light on that. Crystal, before we actually get your thought, you're going to give us, as the chapter author, you have the honor of the last word in this one. Any other things that you remember about this patient specifically, or after they got admitted, or follow-up, just other sort of backstory type of observations on what happened in this specific situation?
I think it's really interesting to review this case. So this was my case 8 years ago, and just looking at how, stroke care at our institution has evolved in that time has been really interesting for me, and just interested to think about where we might go in the future. Like in the future, would this kind of patient just receive mechanical thrombectomy and no TPA at all? Like, where are we going in medicine? So, yeah.
Well, if I was that patient, you might agree, that's what I'd want, right? Okay, all right. So why don't we start with you, Mac Brown? We have 4 minutes left. If you could give us 30 seconds of insight on what you'd like folks to take away from this hour of time they've shared with us.
Yeah, I mean, this is it's kind of one of those things that the AFib probably is going to get the stroke and everything else, and you kind of could see this coming from a mile away. I don't know if the first time they'd evaluated him, like really going through that or not, but doing your best the first time to prevent that second time from happening. Because had he been on the dabigatran, I know he didn't pick it up, but had he picked it up, maybe, probably not, but maybe he could have done something for him. And obviously, it's hard when there's a lot of social issues and everything else, but we can only do the best we can.
Perfect. All right. Amal, some closing thoughts you'd like people to remember to take best care of their patients.
Again, I'll just go back to the last comments that I made. You've got to communicate with the patient, whether you're going to give lytics, and also very importantly, if you're not going to give lytics, even if the patient doesn't qualify at all, I think it's worth talking to them about this clot busting drug that everyone's heard about, and explain to them why they're not going to qualify. And that way, when they don't get it and their neighbor comes out and says they didn't give it to you, they'll be able to say, yeah, they talked to me about that. And that usually is much less likely to result in lawsuit.
Love those thoughts. Evan Price.
Yeah, I agree with Mac that you always have to talk with your patient about, here's the risk, this is why we're anticoagulating you. This gentleman probably already had a clot form because one day of dabigatran wouldn't do anything. But in our normal patient that we see, we would talk to them about it and everything. So that's my biggest point: communicating with your patient.
Okay, Lauren, one thing you're going to take away from this conversation.
I think one thing I'm taking away is that studies have shown that administration of TPA to patients with stroke mimics is typically not harmful. So getting that in as soon as you can is pretty beneficial. But like Dr. Mattu said, I think it is really important to have those conversations beforehand. Once you get that point of care glucose, though, and you have that conversation, I think it's go with the TPA.
Gotcha. Okay, Crystal, drive this train into the station.
I'm going to stay on the thinking about the underlying drivers of dysrhythmias train. And I think one thing I would do differently today than I did managing this patient 8 years ago is I would do a bedside echo and kind of look at his cardiac function, and that may make a difference in how I manage him in the future. But yeah, just thinking about what's causing that dysrhythmia rather than simply purely like, what am I going to do about it?
Yeah, and that's really an important point because, I mean, just with everything we see, we're seeing symptoms in general, right? But symptoms from something, and I sort of make a sort of funny joke, like the patient says, I have kidney pain, and I say, no, you have flank pain. I will tell you if you have kidney pain, right? So, we have to, and that's sort of a joke, obviously, but think about things in a way that the symptoms can maybe be explained by something that'll enable us to take care of the underlying process. Like, for example, that story that I told of the patient with the AFib with the RVR that got the cardiogram from the paramedics. And, I think they did a good job, right? But it turns out that there was an underlying process causing the tachycardia. And then the patient had a history of AFib. So thank you everyone so much for joining. We are taking our break. It's going to be so great. We'll be all of us together, the panelists. I didn't tell them this, but they get a free week at the beach, but they have to spend it with me. So the Bounce Back book clubs will resume with chapter 23 on Monday, October 7th, and you can register either at the website or you can do this QR code. You can see all of the Bounce Back book clubs except for the very first one on that same website, EM, like emergency medicine, bouncebacks.com. And I hope everyone has a great night. Thank you for sharing this time with us. And thanks mostly to these fantastic panelists who prepared and were able to share their expertise with all of us. We'll see you all next time.
Thanks, Mike.
Thanks for having me.